Hello, my dear students. Good morning. This is Dr. Praveen, ENT faculty from Medico. So today we will be covering this ENT, TNT topics, the most common MCQs, and we will discuss that from ear, nose, and throat aspect. Okay. So let us move into the questions. Before that, I always tell you the students the orientation of the ear anatomy is quite important. So always orient yourself about the ear anatomy, the external ear, middle and inner ear, how those things are aligned. And with this orientation, we can answer many of the anatomy questions in ENT, especially in ear. So to start with this diagram, see this is about the right ear, what you are seeing, and the external meatus, which has the bony part, the tympanic bone. That's very important point to note, tympanic ring or tympanic bone, the bony part of the external meatus. And then see this part, the bigger part is called pars tensa of the tympanic membrane, and the smaller part is called pars flaccida of the tympanic membrane. And this region covered by the pars tensa is called mesotympanum, and and this region above the pars flaccida is the epitympanum. So this epitympanum covers the bigger part of the ossicles, that is the head of the malleus and the body of the incus and short pros of the incus. And this pars tensa, that is the mesotympanum, includes the slender part of the ossicles, this handle of the malleus and the long pros of the incus and the stapes. So this is about this middle ear, the ossicular system. And see the face of the yellow colored line. It has this first genu and it has the horizontal part running in the mesotympanum and the epitympanum junction, and this is the second genu, and this is the vertical part of the facial nerve in the posterior wall of the middle ear. And this mastoid is related to the semicircular canals, the posterior part of the inner ear, that we can see in the next picture. See again, this is the view, again the same right ear. We are viewing the middle ear from the anterior part, and more anteriorly we have this cochlea, and more posteriorly we have this vestibular apparatus and the semicircular canals. The thing to notice, this middle ear is related to the cochlea and the mastoid is related to your semicircular canals. So this is the orientation we need to know. If you open into the middle ear, you will enter into the cochlea, and if you open into the mastoid, you will enter into the semicircular part of the inner ear. So this is quite important. And again the facial nerve, a little orientation, it is coming through the inner ear. The labyrinthine part of the facial nerve is here, and we have this first genu, and this is the branch GSPN, greater superficial petrosal nerve, given from the first genu, and it is a horizontal part of the facial nerve which is called as tympanic segment, and this is the second genu of the facial nerve, and we have this vertical part of the facial nerve that is running in the posterior wall of the middle ear, that is called mastoid segment. So again this orientation is quite important, how this middle ear, inner ear, facial nerve is been related. So good, we'll move into the questions. To start with, an elderly man came to ENT OPD with complaints of right ear pain for 3 weeks. On examination, ear was found normal. So which of the structures need not be examined? Need not be examined to find the cause for ear pain. So basically this is a question from rhaphodotalgia, which is a very quite important topic in ear. So which of the structures, please note the question, need not be examined to find the cause for the ear pain? Pharynx, tongue, temporomandibular joint, vestibule of the nose. So simply they are asking which of the structure is not carrying the nerve supply which is related to ear, or not sharing the nerve supply with the ear. So What is the answer? Pharynx, tongue, temporomandibular joint, and vestibule of the nose. Here the pharynx, if you take the pharynx, the major part, the oropharynx and the laryngopharynx are supplied by the sensory supply, glossopharyngeal in the oropharynx and the vagus in the hypopharynx, and both these have the nerve supply to the ear, of course. And tongue, we have this anterior two-third of the tongue, which is the sensory supply of the anterior two-third of the tongue is lingual nerve, which is a branch of V3, and then the posterior one-third of the tongue, which is related to oropharynx. Again, the nerve supply of the oropharynx is glossopharyngeal nerve. Temporomandibular joint, again it is auriculotemporal nerve from the V3, mandibular division of trigeminal nerve. So the V3 has it supplied to the ear also. And the vestibule of the nose is supplied by V2, the maxillary division of the trigeminal nerve, which is not having any supply to the ear. So the answer is vestibule of the nose will not, any infection of the vestibule of the nose will not cause rhaphodotalgia. But the disease in all other areas can cause rhaphodotalgia. That is a point here to note. So coming to the ear innervation, I used to say the mnemonic like this. There are various nerves supplied to the ear. So how to remember a little mnemonic? What is this? Vague friends group. They are the group of friends from many multiple directions, different areas. A vague group of friends. So vague friends group is a mnemonic, and vagus, A for auriculotemporal nerve, G for greater auricular nerve, F for facial nerve, that's quite important nerve supply to the ear, and the last G is again for the glossopharyngeal nerve. Apart from this, a small nerve supply is there, lesser occipital nerve, that is much insignificant, not a big supply to the ear. So this yellow area is supplied by the lesser occipital nerve from the C2. Apart from that, the greater part of the ear is supplied by this greater auricular nerve, the violet area, and this green area is supplied by the vagus nerve, that's quite important, and the more anterior area is supplied by auriculotemporal nerve from the V3. So these are all the nerve supply of the external ear, and the glossopharyngeal, the Jacobson's branch is a supply for the middle ear, we know that. And please remember this, facial nerve fibers. The facial nerve fibers through the vagus, the only sensory supply for the facial nerve, the only general sensory supply for the facial nerve is in the area of the supply of the vagus. So this is the area, the conchal area, the conchal bowl of the ear, pinna, and it's the part behind the concha. So both this medial and the lateral surface of the concha is supplied by the facial nerve through the vagus. So that is the only sensory supply of the facial nerve. That's quite important to note. And this diagram to show you, there are two areas of the face which has a tricky nerve supply or odd man out nerve supply. So this tip of the nose. So we know this generally the upper part is by the ophthalmic division of the trigeminal nerve, and the V2 is the maxillary division of the trigeminal, and V3 is the mandibular division of the trigeminal, which supplies the segmental supply of the sensory supply to the face. And if you take the tip of the nose, so it, logically speaking, it is in the maxillary region, V2 supply, but actually it is not supplied by the V2. It is supplied by the V1 through the which nerve it is supplied by? It is supplied by external branch of anterior ethmoidal nerve, which is a branch of ophthalmic division of trigeminal nerve. External branch of anterior ethmoidal nerve supplies the tip of the nose. And one more area to note, the little part of the mandible. So we know this mandible is supplied by the mandibular branch of the trigeminal, but actually again the angle of the mandible, which is very important to note, the angle of the mandible is supplied not by V3, but this is supplied by greater auricular nerve from C2 C3. And this is very important to note in these two small areas of the face which has a bit different nerve supply, sensory supply. And regarding this applied anatomy of the nerve supply of the external ear, this auricular branch of the vagus, which is otherwise called as Arnold's nerve, Alderman's nerve, Clergyman's nerve, it is responsible for the cough reflex or even it may lead to bradycardia and syncopal attacks in some people during probing. So this is importance of the vagus, which supplies the conchal bowl. And if you take the external meatus, the posterior part of the external meatus is supplied by the vagus, and the anterior part of the external meatus is supplied by the auriculotemporal nerve. As in the picture you can compare, the posterior part is by the vagus and the anterior part is by the auriculotemporal nerve. The tragus and the anterior wall of the external meatus is supplied by the auriculotemporal nerve. Sure. So this is about the vagus, a bit point. And auriculotemporal nerve, which is very important in a MCQ point, injury happens to this nerve during parotidectomy, which leads to a syndrome called Frey syndrome. So what is Frey syndrome? This is gustatory preauricular sweating, a profuse sweating. So if you injure the auriculotemporal nerve during parotidectomy, there is a high chance this nerve will develop faulty regeneration, and this faulty regeneration of the fibers, it supplies the sweat glands of the skin instead of supplying the parotid gland. So this auriculotemporal nerve carries basically post-ganglionic fibers to the parotid. From the optic ganglion, it carries post-ganglionic fibers. So if these fibers are injured, the faulty regeneration happens, and that supplies the sweat glands in the skin rather than supplying the parotid in the recovery phase. So that causes profuse sweating in the preauricular region. That is called Frey syndrome. That is importance of auriculotemporal nerve. And the greater auricular nerve C2, C3, again the point is the most common nerve injured in parotidectomy is the greater auricular nerve. So if you injure the greater auricular nerve, this is very important. A bigger nerve supply of the pinna, you will lose the nerve supply to the major part of the pinna, and that is quite important in the sensory part. So that is a point regarding the greater auricular nerve, the most common nerve getting injured in parotidectomy. And coming to the facial nerve, which supplies through the fibers of auricular branch of the vagus, it has important MCQ points. And first thing, in herpes zoster oticus, Ramsay-Hunt syndrome. So if this facial nerve ganglion is involved, the vesicles will be seen, the painful vesicles will be seen in the supply of this region of the facial nerve supply, in the posterior wall of the external meatus, conchal region, and post-auricular region. And there is a very popular sign in ENT, Hitzelberger sign. What is this Hitzelberger sign? That's quite important. This Hitzelberger sign, please don't forget this point. This is paresthesia of the external meatus and a part of conchal region. This is due to, it happens when the facial nerve is compressed by vestibular schwannoma. So this is the earliest sign of compression of facial nerve by the vestibular schwannoma. So usually, the vestibular schwannoma compresses the first nerve to get compressed is trigeminal nerve. That the earliest sign is loss of corneal reflex. But here, the facial nerve gets compressed. The second nerve to get compressed is the facial nerve. So what is the earliest sign of facial nerve compression? And this is the Hitzelberger sign, panesthesia of the external meatus and the concha. And a very little supply goes from the lesser occipital nerve, not much significant, but you need to remember that also. So referred otalgia, from where the pain refers to ear. So very typically there are few signs from where the pain may be referred, from the any pathology in the larynx and hypopharynx, and very particularly it happens in malignancy. Please remember, this is malignancy. Any elderly people having a laryngeal or hypopharyngeal malignancy, particularly in the supraglottic malignancies and hypopharyngeal piriform fossa malignancies, the pain will be referred to the ear. So any elderly people coming to you with a persistent ear pain, and if you find there is no abnormality in the ear, the very important point is you have to examine keenly the shared area of the ear supply. So the oropharynx, larynx, hypopharynx area should be monitored, keenly observed to look for any malignant changes. That's very important. And auriculotemporal nerve, the pain is referred from anterior tongue through the lingual nerve. That's quite important. And dental caries, yes, the lower dental caries typically supplied by the V3 is causing this ear pain. And TM joint arthralgia, temporomandibular joint arthralgia, that is called Coston syndrome. The patients will be having a pain, a clicking sound, tinnitus, and sometimes vertigo. And through the glossopharyngeal nerve, the pain is referred from oropharynx, base of tongue malignancies or tonsillitis, and very particularly post-tonsillectomy status. So these people, post-tonsillectomy people, children typically complain of ear pain, and that is due to this irritation of the glossopharyngeal nerve, and that causes referred otalgia to the ear. Few points regarding this external meatus. We know this external meatus, the lateral 1/3 is formed by the cartilaginous part and medial 2/3 is formed by the bony part. Such a common point, lateral 1/3 by the cartilaginous and medial 2/3 is by the bony part. And this is exactly opposite to the eustachian tube. So it's quite easy to remember. So only the lateral part of the external meatus, the soft tissue part is cartilaginous, and we know this mastoid, the whole most of the ear structure is within the bony cavity. And the same statement applies. The most of the external meatus is within the bony cavity. So obviously the 2/3, the medial 2/3 is bony and 1/3 only is cartilaginous for the external meatus. So remembering this point is quite easy. And with this point, if you remember this point, you can easily derive the point for the eustachian tube, which is exactly opposite. That the division is same for the eustachian tube, but the part, the component is exactly opposite. For the eustachian tube, the lateral 1/3 is bony and the medial 2/3 is cartilaginous. So easy to remember. Remember the external meatus, you will get the point for eustachian tube. And this lateral 1/3 only is containing the ceruminous glands, wet glands, sebaceous glands, hair follicles, or all those things. And there is no gland in the medial 2/3. And dehiscences, we have the two kinds of dehiscence in both cartilaginous and the bony part. And the MCQ point here is, in which part of the external meatus you will get furunculitis? That is a usual MCQ. In which part of the external meatus you will get furunculitis? Because these furuncles are the infections of the hair follicles, and obviously the hair follicles are situated in the cartilaginous part, and obviously this furunculitis happens only in lateral 1/3. It will not be seen medial 2/3 of the external meatus. Coming to the tympanic membrane and the middle ear. So all are boundaries of Prosoc space, except the Prosoc space is quite important in ear. So Prosoc space, we have to remember all are boundaries of Prosoc space except pars flaccida, head of malleus, neck of malleus, lateral malleolar ligament. So the answer is, it is the space in the epitympanum, a very small space, and this space is very important for the initiation of the cholesteatoma formation, and from there it spreads into the middle ear. So what is this small area is bounded by? So laterally it is bounded by the pars flaccida, and we know this head of malleus is bigger, it is into the epitympanum. The whole head cannot be the medial boundary, only the neck of the malleus forms the medial boundary of the Prosoc space, and superiorly it is bounded by lateral malleolar ligament. So the answer for this question is head of the malleus. It is not the boundary of Prosoc space. So a few points regarding the tympanic membrane first, and then we will move on to the Prosoc space, the picture. So we have this tympanic membrane. I told you this bigger part is pars tensa and the smaller part is pars flaccida, and this tensa is lined by the fibrous ring called annulus, and this pars flaccida do not have this annulus. It is a bare bony rim, and that is called notch of Rivinus. It is all given in this tabular column. And that pars flaccida is otherwise called as Sharpnell's membrane. Tensa has 3 layers. Middle fibrous layer is more prominent in tensa, but in flaccida, the middle fibrous layer is more deficit. It is more thinner. So this is more important, and the color of the tympanic membrane is purely white or purely gray in color, and which is the another MCQ, which is quite important MCQ, which is the most prominent part or the point of the tympanic membrane. It is a lateral process of the malleus. It's quite important. Which is a lateral process of the malleus? See, this is the handle of the malleus, and the middle part, the tip of the handle is called umbo. We know that. And this is the cone of light shined in the antero-inferior part of the tympanic membrane, and the superior part of this handle of malleus is the lateral process of the malleus. This point, see this point in this picture, in both this picture, The prominent point of the malleus is called lateral process of malleus. So very simply, I tell you one thing. The structure beneath this lateral process malleus is pars tensa, and the structure above this lateral process malleus is pars flaccida. That's quite important. So beneath is pars tensa and above is pars flaccida. So this is a differentiation, and this is the most prominent point. Means in even extensive disease process like cholestoma, this process gets damaged only in the later stages. It gives a clue about the anatomy of the whole tympanic membrane. Even if you find very extensive damage to the tympanic membrane, with this point we can identify where you are actually. So what is the orientation, which is inferior, where is superior, all those things you can have idea during surgery. That's quite important. So Prosoc space, what are the points to note in the Prosoc space? So this is what the Prosoc space. I told you again, we are viewing the middle ear from the anterior wall. Remember this, and this is the pars tensa and this is the pars flaccida. So this area, what is this? Yes. This smaller area is called Prosoc space, that's all. So obviously, the laterally by the pars flaccida and medially by the neck of the malleus. So this is the head of the malleus, which is a bigger, more superiorly placed. So neck of the malleus forms the medial boundary of the Prosoc space, and this is lateral malleolar ligament, which forms the superior boundary of the Prosoc space. So this Prosoc space, this is present in this epitympanum, which is covered by the pars flaccida. Of course, it is epitympanum. We know this epitympanum is more chance of getting the negative pressure, and this negative pressure leads to retraction pockets. So obviously retraction pockets are quite common in this place of Prosoc space. So how this retraction pocket looks like, this is how the retraction pockets looks like. See again, this bigger area is the pars tensa, this is the prominent part, the lateral process of malleus, and this is a retraction pocket. So once the retraction pocket happens, the keratin debris, the squamous epithelium with keratin debris gets loculated, gets collected, and that will grow inside the middle ear, and that is called cholesteatoma. And hence the initiation of formation of the cholesteatoma is happening in the Prosoc space. So this is about this Prosoc space. Next question, a picture-based question. A CSOM patient was planned for surgery. After doing cortical mastoidectomy, the surgeon opened the area marked in the picture, and this is the area marked in the question, like this. Okay. So the surgeon opened the area marked in the picture. The following are true regarding the area except. So what is the area he has opened? So after doing cortical mastoidectomy, he has opened the area. So this is very, very important part in the middle ear area. This anatomy is quite important. So we have to remember. So after doing a cortical mastoidectomy, more superiorly, you will be seeing a naturally existing opening, which is connected between the epitympanum and the mastoid. And through that opening, please see that through that opening, we can see the ossicle. So this is the incus, the body of the incus. Also, what is the opening that is naturally existing? That is called additus, connecting the epitympanum and the mastoid antrum. So if you want to operate from the mastoid into the middle ear, if you want to expose the posterior part of the middle ear, that is posterior mesotympanum, so this area we have to open iatrogenically. It will be covered by bone actually. If you drill the bone in this area correctly, you will enter into the posterior mesotympanum. So exposing the oval window and the round window. See this opening, round window. So this two areas we can expose by opening this area. So this is called facial recess approach. So this area is called facial recess. So the following are true regarding the area except posterior tympanotomy. Medially it is bounded by chorda tympani. Also done in cochlear implant surgery, round window can be approached through it. So it is called as posterior tympanotomy. Of course, It is present in the posterior wall, which is related to the mastoid. Yes, posterior tympanotomy. Medially, it is bounded by chorda tympani. No, the medial boundary of the facial recess is bounded by the vertical part of the facial nerve. This is the vertical part of the facial nerve, of course, which is the medial boundary. And laterally, the facial nerve gives a branch like this, which goes anteriorly to exit out. So this branch is called chorda tympani. So the chorda tympani is a lateral branch. So it is not a medial branch. So answer is B. It is also done in cochlear implant surgery. Yes, we have to expose a round window to place the electrodes into the scala tympani. So that's why this facial rays approach is very important approach in cochlear implant surgery. A round window can be approached through it. Yes, that is what it is very useful in cochlear implant. So these are all the points, and the answer is B for this question. So coming to the middle ear, what are all the structures in the middle ear? We have to know what are all the important areas to concentrate. So it is divided into epitympanum, meso and hypotympanum. We all know that. Again, this is a wonderful picture, a schematic picture where we are seeing the middle ear from the anterior part. That is from the eustachian tube part, we are viewing the middle ear. So this is the tympanic membrane, and this prominent part is called the promontory, formed by the basal tone of the cochlea. We have this malleus with its neck and handle of the malleus, and we have this incus, body of the incus. We have the two process. This is the short process of the incus, and this is the long process of the incus. Quite important. The short process of the incus is pointed towards posterior wall of the mesotympanum. That is very important. Posterior wall of the middle ear. And what is this point where the short process of the incus is lying? You know that, and that point is called fossa incutis. Please remember that point, fossa incutis. And we have this opening here connecting this epitympanum into the mastoid. It is called additus, very simply. And see this very clearly. We have this facial nerve, the anterior end of the facial nerve, which travels horizontally here, and this is the second genu, and it travels vertically downwards like this. So this is the facial nerve, and it gives a branch. The yellow line is called chorda tympani. So that is a branch of the facial nerve from the vertical segment of the facial nerve, which passes between this neck of the malleus and the long process of the incus. So these are all the anatomical points. And there is a very simple line diagram with for each wall I have given you to understand what are the important structures in each wall of the middle ear. So to remember in an easier way, on each wall there are three rounds or oval or round shaped structures. To remember, those three structures are very important in these areas. So lateral wall, we know pars tensa, and above is pars flaccida, and still above it is the scutum. What is the scutum? This is the scutum. This bone is the scutum. So it is the bony part that covers the attic, that covers the epitympanum. The lateral wall of the epitympanum is the scutum. So these are the structures in the lateral wall: pars tensa, pars flaccida, and the scutum. Again, if you take a real picture, this is like this. The pars tensa has been peeled away with its annulus, and the flaccida is been removed to expose the neck of the malleus, and this bone is the scutum. Very simple. This bone is the scutum above this pars flaccida. The lateral wall of the epitympanum attic is the scutum. Okay. And you can very clearly see the handle of malleus again. This is the lateral process of the malleus again. So this is exposing the middle ear. Okay. Coming to the medial wall, on elevating the tympanic membrane, the straight opposite wall, against wall, which you are seeing is the medial wall, that is the inner ear wall. So the inner ear wall, the middle bulge is the promontory. So that is this one, number one. The middle bony bulge, what you are seeing, a prominent bony bulge is formed by the basal tone of cochlea, that is promontory, and surrounding that again three structures to remember. More posteriorly, we have this oval window and a round window. We know that. And more anteriorly, we have a bony prominence, which is called as processus cochleariformis, which is very quite important structure. So this oval window is covered by the footplate of the stapes, and this is a round window. postero-superiorly and postero-inferiorly, and antero-superiorly is the bony prominence called processus cochleariformis. So there are few important MCQ points for the process cochleariformis. What is this? And this is again the most prominent structure of the middle ear. We have seen the most prominent structure of the tympanic membrane. Please remember that lateral process of the malleus. And the most prominent structure of the middle ear is processus cochleariformis. Okay. And the tensor tympanic muscle gets attached to this process cochleariformis and gets a turn. Tendon appears and which gets attached to the neck of the malleus. Okay. And this is the third point is very important. This is an important landmark for first genu of the facial nerve. So for the facial nerve, there are many landmarks for the second genu, but the most important landmark for the first genu of the facial nerve is the processus cochleariformis. So this is very important points regarding process cochleariformis. Anterior wall, which is called as carotid wall, we have this again eustachian tube orifice, above that the canal for tensor tympani, and the small canal is canal of Hoogier, where the chorda tympani exits out. So again, this is the thing, eustachian tube orifice. So we have to please correlate with the real pictures, because picture anatomy is very important nowadays. There is many spotters picture based questions are being asked. So how a real anatomy picture of the middle ear appears like. So that's why I have given the pictures like this. So this is the eustachian tube orifice, and this is the bony canal of the tensor tympani. See, please remember, this gets attached to a bony prominence here, that is called processus cochleariformis, and above that there will be a small opening, that is exit point for the chorda tympani. So these are the things. So this is how a real medial wall of the middle ear appears like: the promontory, the oval window closed by the stapes, and the round window. So these are all the structures, and you can see the horizontal part of the face in a pinkish line above all these structures is the horizontal segment of the facial nerve. That is how it appears like. So obviously this is the first genu area which is related to the processus cochleariformis. Please remember this point. And this is the second genu area, and from there the facial nerve passes vertically downwards in the posterior wall of the middle ear. Okay, that we will see. So coming to the posterior wall of the middle ear, so again the line diagram with the three structures from above downwards on the mastoid. And the pyramidal process is the second important structure in the posterior wall, and the vertical part of the facial nerve is the third important structure in the posterior wall of the middle ear. Check. And here we have the two areas on either side of the posterior wall, the vertical part of the facial nerve. Two depressants on the lateral aspect and on the medial aspect. So the depression on the medial aspect is called sinus tympani, and depression on the lateral aspect is called facial recess. A shallow depression will be present. Think of facial nerve like a mountain ridge, mountain range. There will be two valleys on either side of a mountain, obviously. So facial nerve runs like a mountain ridge in the posterior wall of the middle ear, and on either side we have a shallow depression. So we have the names for those depressants. So the lateral one is called facial recess, and the medial one is called sinus tympani. And this is of course the branch from the facial nerve, chorda tympani from the vertical part of the facial nerve. So obviously here the area bounded between the vertical part of the facial nerve and the chorda tympani is called facial recess. So this is what this anatomy, facial recess. Though medially it is by the vertical part of the facial nerve, and laterally by the chorda tympani, and superiorly by the point called fossa incutis. I told you now, the fossa incutis is the point where the short process of the incus is large. So this is about the posterior wall of the middle ear. And sinus tympani boundaries, please correlate again with this same picture. This is what this facial recess we are talking about. This is the vertical part of the facial nerve running downwards, and this is the chorda tympani, and this area of the posterior wall is called facial recess, and of course the superior it is bounded by fossa incutis. So these are all the area structures in the posterior wall of the middle ear. And coming to the sinus tympani, few points. This is the hidden area of cholesteatoma, more medially placed hidden area of the cholesteatoma. And medially to vertical part of the facial nerve, that's what we have seen now. And it is bounded by ponticulus above and subiculum below. I show you with the diagram. See, from the inner ear, from the middle ear side, I will show this superiorly by the aditus, and the second point is pyramidal process, and the third point is facial nerve, vertical part of the facial nerve. These are the three important structures in the posterior wall of the middle ear. Okay. If you see from the mastoid area, so this is the facial recess area. This is the vertical part of the facial nerve, and the choroid tympani will be going like this. So this is the boundaries of the facial recess, and superiorly, the point where the short process of the incus is lodging is called fossa incudis. So this is the boundaries of the facial recess, and if you skeletonize more very clearly, you can see this picture like this. The vertical part of the facial nerve, see the slender nerve, choroid tympani nerve, and we have this fossa incudis, short process of the incus. So we can see this incudostepidal joint assembly which is placed in the oval window and the small opening round window. So these are all the points to note, and I already told you this mastoid is related to the semicircular canals. So this is a lateral semicircular canal dome, and this is the posterior semicircular canal dome, and this is the superior semicircular canal dome. So these are all the dome of the semicircular canals which is related to the mastoid. So these anatomical pictures are quite important. Please remember, many questions will be asked from these anatomical pictures. That's why I am telling you with these pictures. Please remember. So this is a small mnemonic. I used to say this is like a slingshot. We used to hit the birds. The people are playing in the village side. So vertical part of the facial nerve medially, choroid tympani laterally, and the fossa incudis superiorly. It forms the typical boundaries of the facial recess, and the small area which is medial to the vertical part of the facial nerve is the sinus tympani. So the small bony ridge is called ponticulus, which is attached from the promontory to the pyramidal process, and this is subiculum. This process is called subiculum, which is below the sinus tympani. So sinus tympani is bounded above by the ponticulus, below by the subiculum. Yes, these are all the points to note. Which type of synovial joint is seen in this picture? And the point they have noted is this point, this joint. Which type of synovial joint is seen in this picture? This is incudo-malleal joint. So what is this joint type? This is saddle type. Ball and socket, saddle, pivot, plane. So the points to notice, both are synovial joints, and the type of joint in the incudo-malleolar junction is called saddle joint, and incudostepedial joint is like, there is a ball and socket type. This is how the incudostepedial joint will be looking like. So the incus, the tip of the incus, the lenticular process of the incus like a ball, and the head of the stapes accommodates that like a socket. Ball and socket type of synovial joint is in incudostepedial. Yes. Incus and stapes, and this is saddle, incus and malleus. Coming to the points regarding McEwen's triangle, coming to the mastoid. So we have finished most of the areas of the middle ear. Coming to the McEwen's triangle. In the McEwen's triangle, so what are all the areas to note in the McEwen's triangle? So this I told you, tympanic ring, that is the bony part of the extremitus, very important point. Bony part of the extremitus, and this is a mastoid area. So McEwen's triangle, it is a landmark for the mastoid antrum. The antrum, that is the persistent and most prominent mastoid air cell is the antrum. So it lies 1.25 to 1.5 centimeter deep to the McEwen's triangle. So while exposing this mastoid, we have to create this triangle, and if you drill in this triangle exactly, you will open into the antrum, you will not injure any other structure. So superiorly, this McEwen's triangle is bounded by supratemporal line. This line is the superior line, supratemporal line. And anteriorly, this bony prominence. What is this bony prominence? Very important. That bony prominence is called Henle spine. So anteriorly, draw a line along the Henle spine, and posteriorly, a line is drawn along the tangent line to the posterior meatal wall. So this is a tangent line to the posterior meatal wall. So this area is called the McEwen's triangle. If you open, which is typically see a bit posterior superior to the extremiatus. So this area is called the McEwen's triangle. If you open, you will enter into the masseter. What is this partition that is seen inside the mastoid? It is a radiological picture. We have this middle ear like here, and we have the mastoid here. And the septation is between the superficial cells and deeper cells. The superficial cells are called squamous cells, and deeper cells are called petrocell cells. So this is the embryonic remnant which separates the superficial and deeper cells of the mastoid air cell system, and this septum is called corner septum. So the antrum, this is antrum. Antrum will be deeper to the corner septum always. So if you see this septum in the radiology in the CT scan, you have to drill the septum to enter into the antrum. Otherwise, you will not enter into the antrum. So this is recognizing this septum is very important in CT scan, which is quite present only in children up to 2 years of age. After that, this corner septum will disappear, but very rarely in few adults it will persist. So that is called corner septum, petrosquamous septation, petrosquamous septation. So with this, I will show you a small diagram which is quite important, exposing all the medial wall of the whole middle ear and the mastoid. We have removed the extremiatus, the middle ear, and the mastoid has been drilled out. The whole medial wall is exposed. The whole inner ear wall is exposed. How it looks like. So with this picture, we can see this malleus and incus are clearly seen. Two ossicles are clearly seen. And very importantly, we can see this horizontal part of the facial nerve. And second genu of the facial nerve. Again, the vertical part of the facial nerve. So these are the parts of the facial nerve. So with this, we can very clearly say, and this is a cauda tympani. This is a cauda tympani branch. So we know I told you that for the first genu of the facial nerve, it is where the first genu is present. The only important landmark is processus cochleariformis. And for the second genu, there are very important landmarks all around, because one important MCQ point is the most common site of iatrogenic injury to the facial nerve is second genu of the facial nerve, because the second genu is related to the mastoid area. So while opening the mastoid antrum, you may injure the second genu of the facial nerve if you are not cautious. That's why the McEwen's triangle landmark is very useful. So we have to have some important landmarks to identify the second genu and to avoid injuring the second genu. What are all the landmarks? See, second genu is lying in this area, and posterior superior to the second genu is the dome of the lateral semicircular canal. Please remember, the dome of the lateral semicircular canal is posterior superior to the second genu, and antero-inferiorly we have the oval window region. Antero-inferiorly we have the oval window region. At the area of the second genu, we have this prominent process called pyramidal process. We have the prominent process called pyramidal process. And fossa incutis, this is also related to the second genu. I told you where the short process incus is lying is called fossa incutis. I again show this, correlate this picture with the previous picture, don't worry. So this fossa incutis, the second genu is lying inferomedially. Compare with this, it is lying inferomedially to the fossa incutis. So these are all the areas, these are all the structures around the second genu with which we can have a good landmark. See, Again, the same picture. Okay. So this dome of the lateral semicircular canal, this is the second genu or the facial nerve. So it is postero-superior, and here oval window is antero-inferior, and this is the fossa incudis I told you, and the second genu is inferior-medial, inferior and medial, and at the point of second genu we have we have the prominent process called pyramidal process, which gives us stapedius muscle. So these are all the points to remember around the second genu. So these are all important anatomical landmarks for the second genu of the facial nerve. This is how it is more crowded, and with these landmarks we can say which is second genu. So that's very important point, my dear students. So coming to the mastoid, few other things. There are two things, Trotman's triangle and Sitterley's angle. What is Trotman's triangle? This area is bounded by the bony labyrinth anteriorly, sigmoid sinus posteriorly, and superior petrosal sinus superiorly. So this gives approach from the mastoid into the posterior cranial fossa. Very simple. After opening the mastoid, cortical mastoidectomy, we have this bony labyrinth anteriorly, that is the semicircular canals, the bony labyrinth more anteriorly, and posteriorly we know the sigmoid sinus is present, and superiorly we have the sinus, that is the superior petrosal sinus will be there, and this area is called Trotman's triangle. If you drill this area, you will enter into the posterior cranial fossa. You can enter the posterior cranial fossa, or the disease may extend there into the posterior cranial fossa. So this is about Trotman's triangle. And what is Sitterley's angle? This is called a sinodural angle. Again, this is sinodural angle. This is a sinus plate and this is a dural plate. So this angle is called a sinodural angle. And what is the significance of this Sitterley's angle? Again, in the middle ear we have seen the sinus tympani is a hidden area for cholesteatoma. The cholesteatoma hides deep into the sinus tympani. Very keenly we have to explore that area to get rid of cholesteatoma. Likewise in the mastoid, the hidden area for cholesteatoma is sinodural angle, Sitterley's angle. So if you do not expose this area properly, you may leave behind the cholesteatoma that will lead on to residual and recurrent cholesteatoma. So this is very important. Coming to the inner ear, points to note in the inner ear. An infant was treated for meningitis. During the time of discharge, baby was found not responding to the sounds. So the baby had meningitis, and the time of discharge it is not responding to the sounds. Bera shows profound SN hearing loss for the baby, and the baby was diagnosed as having labyrinthitis. That's why the baby has profound SN hearing loss after meningitis. So what is the probable route of transmission of infection from the intracranium into the inner ear? So cochlear aqueduct, endolymphatic sac, vestibular aqueduct, round window. So we easily rule out one thing, which is easily we can rule out round window. Round window is a connection between the middle ear and the inner ear. It cannot be a connection between the inner ear and the intracranium. So D is not an answer. So cochlear aqueduct, endolymphatic sac, and vestibular aqueduct are the three options where it's been given. And simply, the endolymphatic sac is the terminal part of the vestibular aqueduct. Both are more or less in the same area. So vestibular aqueduct carries the endolymphatic duct and ends in the endolymphatic sac. And the answer is cochlear aqueduct. This cochlear aqueduct is connecting the meningeal space, subarachnoid space with the scala tympani. So the perilymph drains through the cochlear aqueduct, and we know the perilymph is more or less it's a CS of fluid. So the perilymph drainage pathway through which any infections from the intracranium can spread into the inner ear and can cause labyrinthitis. Very important area of transmission. So the cochlear aqueduct is a very important duct through which infections carries. And the mnemonic is CAP. Cochlear aqueduct carries perilymph, and the vestibular aqueduct carries endolymph, through which the endolymph drains, through which the perilymph drains. That's what cap. So cochlear aqueduct is for perilymph drainage and endolymphatic drainage is through the vestibular aqueduct. So we have this around the inner ear, we have the openings called oval window is one opening, round window is another opening, and internal acoustic meatus is the third opening, and we have these two more openings called vestibular aqueduct and the cochlear aqueduct. So these are the two openings. So obviously the vestibular aqueduct carries this endolymphatic duct, and that ends in endolymphatic sac. And this cochlear aqueduct from the scala tympani, it drains into subarachnoid space. So this is all about this openings around the inner ear. So the cochlear aqueduct is a duct from which the subarachnoid infections, that is the meningeal infections, spread into the inner ear. Okay. So difference between the endolymph and perilymph. Endolymph contains more potassium. Of course, it is more energy loaded. It contains the positive ions, positive current endolymph. And the perilymph, which is very similar to CSF, extracellular fluid, it has a more sodium. Okay. And glucose, again, it is very similar. 2/3 of the blood glucose will be present in perilymph. It is similar to CSF. And secretion, this endolymph is secreted by the stria vascularis and dark cells, and this perilymph is from the CSF. It's more like ultrafiltrate of the CSF. Many theories are there, more similar to CSF. And absorption, very importantly, through the endolymphatic duct into the endolymphatic sac is the absorption for the endolymph. And this endolymphatic sac is present in the subdural space. It is enclosed by the two layers of dura. So subdural space is the typical point of endolymphatic sac, and this perilymph, it drains through the cochlear aqueduct into the subarachnoid space. So that is the point. Which of the following statements are correct about the hair cells? So recently been asked a question, and hair cells anatomy we need to know a little, and some mnemonics I tell you to remember in an easier way. There is one row of inner hair cells and 3 rows of outer hair cells. Inner hair cells are responsible for transmitting auditory impulses, that is afferent. Majority of the afferent fibers of spiral ganglion supply the inner hair cells. Most of the afferents are from the inner hair cells. Outer hair cells send the electric signals to the brain in response to the sound vibrations. Outer hair cells are afferent. That's what this statement means. So which is incorrect, which is correct? So there is one row of inner hair cells and 3 rows of outer hair cells. Yes. Inner hair cells are responsible for transmitting the auditory impulse. Yes. Majority of the afferent fibers of the spiral ganglion supply the inner hair cells. Yes. And outer hair cells send the signals to the brain in response to sound vibration. The outer hair cells play more of efferent role rather than afferent role. So the answer is 1, 2, 3 are correct and 4 is not correct. So 1, 2, 3 answer is B. So the difference between this inner hair cell and outer hair cells are in this organ of cortex. Inner hair cells are one row and it is around 3000, and it is 3 to 4 rows and it is around 12,000. And these inner hair cells are mainly afferent and outer hair cells are efferent in nature. It modifies the functions of cochlea. They are called as cochlear amplifiers. It can modify the vibration of the basilar membrane. It can stiffen the membrane and can loosen the membrane. So based on the stiffening of the basilar membrane, the vibration modifies. So it can make the cochlea to respond to certain sounds and to not to respond to certain sounds. So it is efferent to the cochlea, cochlear amplifier mechanism, efferent pathway to the cochlea. And inner hair cells are very resistant to any damage. The outer hair cells are easily damaged by the ototoxicity and noise-induced hearing loss. This is quite important, and the mnemonic I used to say is inner hair cells, I. And we have the outer hair cells, O. Like this, a power switch. This is a symbol of power switch. So the inner hair cells, I, a single row. Outer, it is like arena, gallery. In gallery, there will be multiple rows surrounding the arena. So outer hair cells are multiple rows, more in number, more rows will be there, inner and outer hair cells difference. And then which is afferent, which is efferent. You can write these vowels like this: A, E, I, O, and U. That is a single odd man out. So inner hair cells are afferent, outer hair cells are efferent. So the simple way of writing: A, E, I, O, U. So inner hair cells are afferent, outer hair cells are efferent. So this is the difference between inner hair cell, outer hair cells. Inner hair cells are single, outer hair cells are multiple rows, inner hair cells are afferent, outer hair cells are efferent. So basically this eighth nerve carries most of the afferent fibers. We need to hear basically. So afferent fibers are most prominent in the eighth nerve, and of course they are from the inner hair cells. Afferent fibers innervates the inner hair cells. So this is what the points regarding inner and the outer hair cells. Coming to the last area of the inner ear, internal acoustic meatus, where we have this, it is like a canal, internal acoustic meatus, which is divided into a vertical crest of the bone and a horizontal crest of the bone. So the vertical crest is called Bill's bar and the horizontal crest is called falciform crest or transverse crest. And within this we have this bundles of nerves: 1, 2, 3, and 4. So we have this bundles. What are the bundles? We have this antero-superiorly, antero-inferiorly, postero-superior, and postero-inferior. So the first point to note is the only nerve, if you remember this, all the other nerves are easy to remember. So antero-superiority is the facial nerve. I used to say this as a mnemonic fast. The facial nerve is an antero-superior terminal. The facial nerve is an antero-superior terminal. That is a more important nerve we consider during surgery. So remember, it is more anterior and more superior. It has more preference in the presence in the interacoustic meatus. So fast facial nerve is an antero-superior terminal. So if you remember in this way, we have the areas left out: antero-inferior and postero-superior and postero-inferior. I told you the anterior part of the inner, the first slide I have told you, the anterior part of the inner ear is cochlea and the posterior part of the inner ear is semicircular canals. So obviously the antero-inferior, already a nerve is present in the antero-superior part. So what is a nerve that can be present in the antero-inferior part of the internal acoustic meatus? Anterior part is cochlea. So the antero-inferior nerve will be cochlear nerve. And of course, the posterior bundles will be vestibular bundles. We have the two bundles. So postero-superior have the superior vestibular bundle and postero-inferior has inferior vestibular bundle. So this is how the internal acoustic meatus is been occupied by this bundles, and the vertical crest divides the facial nerve and the superior vestibular nerve. So that is the question they will be asking in the internal acoustic meatus. Please remember in this way. So this is a finger diagram, is very easy to remember. This is the Bill's bar and this is the horizontal crest, that is called falciform crest. Yes, okay. So a small break. After the break, we will come back to the questions. Thank you.